I'm Carl Goodyear. I'm Professor of Translational Immunology at the University of Glasgow. And I'm going to talk to you today about the work we're doing on molecular profiling of autoimmune diseases, with the idea of trying to see whether we can predict response to therapy, any drugs that we might give our patients, and about trying to understand the evolution of disease at an immunological level. So they're the disclaimers for the talk. And if I just go right into the actual talk itself now, and I'm going to talk to you about rheumatoid arthritis, an exemplar of the work that we do. And just briefly, rheumatoid arthritis in a nutshell is the idea that we all understand that this is a sort of a disease that affects the joints. You get joint erosion, but it's much more complicated than that. It's a systemic disease. It can affect the cardiovascular system. It can affect the vasculature. It has very many comorbidities associated with it. And because of that, it's actually not one disease, really. It's more of a syndrome. And all patients are quite heterogeneous when you compare them to each other. Yes, they might display with joint destruction, but it's underlying molecular and immunopathology that really is quite heterogeneous. And actually having an understanding of that will potentially allow us to treat people in much better ways. So to give you an idea of treatments, right now there are no permanent cures. People are usually treated, and what you're doing is managing the condition. You're controlling the inflammation, you're suppressing all the autoimmune and anti-inflammatory responses, but you're not really putting someone back into a healthy scenario. The other aspect that's an issue is that only 40% of patients or don't really respond very well to their therapies that are being given. Now, there are a range of drugs that can be given, from synthetic DMARDs, and a DMARD is a disease-modifying antirheumatic drug. So there's synthetic ones that have been around for many years, and then now with the advent of biological therapies, we have biological DMARDs. And you can see that on the right-hand side of the slide with the pharmaceutical therapeutic areas, the antirheumatics are number 2 in the world in terms of the amount of sales and market share, and they're a big component of the market. So there's a lot going in there trying to understand this. Now, there's lots of different ways of looking at RA treatments and their success rates. And like I've already said, there's a whole range of options. But this slide is just to exemplify that there's no treatment option that's universally effective. If you look across all of these different studies with different drugs, if you look at the profiles of response, they're all essentially the same. So no matter what type of study you do, you always see the same number of people who have a very good response to only a moderate response. And we're trying to understand why that's the case. What is the difference? Again, it's a very heterogeneous disease, which implies that all patients are very different. Why are they not responding in the same way? Now, when we think about the normal clinical setting and what drives treatment decisions right now, we have to understand what clinicians are doing to see if we can subsequently change what they could do if we had the right types of tests. What generally happens is disease is looked at, and there's a clinical disease activity score that's used. So a patient will come in, they're reviewed, their clinical disease activity is assessed, and the physician will then decide what they're going to do. And they might use some things like acute phase responses or autoantibody status, but generally they look at the disease, they look at the guidelines, and they treat them according to the guidelines. They might look at x-rays and think about erosions or the functional status, and they might sort of document comorbidities, but none of those really drive the treatment decisions. The treatment decisions are driven by a pragmatic approach where people have been treating rheumatoid arthritis patients for many years, committees are formed, and they decide what to give. What's not done, or is very rarely done, is actually understanding the disease at a molecular or cellular or clinical characterization, and then saying, okay, what is this patient's RA? Recognize that heterogeneity, understand the clinical setting, the comorbidities that might be associated, and the actual molecular underpinning pathogenesis that might give you an insight into what they might respond to best in terms of the drugs that are available. And therefore, because of that, you don't have things like predictive biomarkers where you're using either the natural history or response prediction for particular drugs, or even whether the drug might be toxic in that particular individual. And therefore, you can't do stratification and you can't do personalized healthcare either. So this comes into biomarkers in RA and the potential to inform clinical decisions. And that's what it's all about. The whole reason for doing this is to actually help clinicians make a decision about what the treatment should be. So what you might have is this very heterogeneous group of RA patients to come in. And the question is, how do you actually decide which drug to give them? Do you give them the pink one, the yellow one, or the green one. And we don't know right now. It's a guess. You give them what you think is right. So what we really want to move to is a point where we say, okay, when do we treat this individual? And when we know when we're going to treat them, what do we treat them with? So at diagnosis, you might give them one type of treatment, but if there's going to be a treatment change or they flare, you need to think about a different drug you might want to do. In addition to that, we also might want to think about how long to continue the treatment. Can we get people into drug-induced remission if we treat them with the right drug at the right time? And that's that strap line at the bottom, the right treatment for the right patient at the right time. That's the end game. That's where we want to go. Now, personalized medicine has been around for a long time. People have been thinking about this for a long, long time, especially in rheumatology. And there was a very nice sort of systematic review done on this. And the objective was to see if there were any biomarkers that had clinical utility. And the long and short of it is, right now, there aren't any. And people are still working on this. So there's a massive unmet clinical need, and we need to sort of achieve that, hopefully, within the next 5 to 10 years. Now, that's not to say that people have not been using clinical predictors in RA to try and understand what's going on. And generally, people have been looking at very big data sets, these registry data sets, and extrapolating clinical data. And you can actually see that you can associate certain things with someone who might have a good response. So if they don't smoke, if they're male, if they don't need glucocorticoids, things along those lines can be associated with, at a population level, whether someone will or will not have a good response. But they don't come down to the point where you can use them with an individual. And that's where we need to get to. Can you use something at an individual level? Now, thinking about biomarkers as well, again, biomarkers have been used in the RA field for a long time. The classical biomarker in rheumatoid arthritis is autoantibodies. We know that there's rheumatoid factor, which has been used for a long, long time. And obviously within the last decade or so, we've had the anti-citrullinated proteins and the various different other antibodies that have been associated with post-translational modifications. In addition to that, there's acute phase responses such as CRP or ESR and other particular biomarkers that have been found in the circulation. But again, none of those actually on their own or even in combination have the ability to say whether someone will or will not respond to disease. They'll tell you that someone's got RA of a particular flavor, but it doesn't help the treatment response aspect. So when we're thinking about this, we say, okay, well, yes, there's an inkling that there might be something there, but how do we actually get that all-knowing biomarker that can allow us to really inform clinical decisions? Now, there are obviously lots of different ways, and people are looking at various different things. And the question is, what do you measure? And I would say up front that I personally don't think it matters what you measure. I think what you need to do is find the one that works in a particular setting you have and use it. And it might not be one, it could be a combination. So it could be that you're looking at RNA or DNA, it could be proteomics, metabolomics, etc. But as long as you look at the various omics, there is the option to do that. The other question is, where do you look? Well, do you want to look in peripheral blood or in the synovium? The easiest thing would be to look in peripheral blood because it requires a blood sample. Patients are used to that, whereas synovium requires a biopsy, which is a lot more painful, potentially. So, coming to the question in hand, can precision medicine help you stratify early RA patients? And the idea is, what you want to do is remove people who don't respond to a drug and only treat the ones that do respond. And then, what you actually have is a scenario where you can move those non-responders onto an alternative drug which might work for them. That's the end game. To do this, we used the Scottish Early Arthritis Inception cohort that we'd created in Scotland. It was pan-Scotland wide, and we got around about 1,200 patients involved. And we got them at diagnosis before they'd received treatment, and then 6 months and 12 months after treatment. And we looked at various different samples. All the clinical measures were done. And we basically then looked to see what we could do. Now, I'm not going to go through all of these different things. I've only got time to talk to you about just a couple of different things we've done. But we were getting DNA, we were getting RNA, so we could do whole blood transcriptomics. We've got all the serum plasma for all the proteomics. We've got cells through flow cytometry and urine for metabolomics. But we also got PBMCs for epigenomics. And I'm just going to give you a very quick snapshot of the epigenomic aspect that we looked at, just to give you an idea that this can work. So this is it, this one slide that I'm just going to sort of provide you with an idea how biomarkers can be useful in informing treatment responses. what we did in this particular aspect of the study was we looked at harnessing three-dimensional chromosomal architecture of the genome. I can't go into all the details, but long and short of it is that if we actually measured, and on the right-hand side I've sort of put in a schematic, loops in DNA, where these loops come together, and we can measure these loops at a molecular level, and they're all over the genome, but these particular 5 loops around these 5 genes are associated with them. If we measured just these 5 loops in all RA patients, we could then categorize them into responders and non-responders based on that loop signature. And on the left-hand side, you see an area of the curve, which tells us that we are, by just this one signature, able to predict within 90% accuracy whether someone will or will not respond to their first drug, which in this instance was methotrexate, the MTX. So actually, at a molecular level, using sort of DNA three-dimensional architecture, you can predict whether someone will or will not respond to a drug when they've just been diagnosed with rheumatoid arthritis. So again, really does exemplify what you can do. Now, that's for one drug, and that doesn't necessarily work for all drugs. So we need to understand other markers. So we have other things that we want to look at. So one of the questions we've asked is, can we use other immunological biomarkers for response to therapy? Now, this now gets into sort of the immunological aspect of a lot of the studies that we do. And this comes to B cells and B cell repertoire analysis. And the question is, can you use the B cell repertoire analysis to predict response? I already told you that we use autoantibodies all the time, rheumatoid factor and anti-CCP, to give us an idea in terms of the clinical setting. Now we want to say, okay, well, can you use a repertoire analysis, which is defined initially in the bone marrow when we're making the combinations of VDs and Js, and then getting into the mature population. So we looked in the mature population, and we used an assay by Thermo Fisher, which is the iron torrent BCR heavy chain long read assay, and said, okay, if we look at the entire repertoire, what does that tell us about being able to predict response to therapy? And you can see sort of underneath the schematic, which shows you how we did this, that actually we can profile someone's entire immune repertoire across all their different immunoglobulins to understand lots of different aspects of their BCR repertoire, CDR length, etc. And by doing that, long story short, is that we were able to look at the frequency of highly mutated IgM and IgD B cells. And by looking at that, we were able to predict the response again to methotrexate between responders and non-responders. And you can see that we have a much higher frequency of these mutated IgMs and IgDs in the non-responders compared to responders. And again, the ROT curve analysis shows you that in this instance, you're looking at around about 85% predictive power. So yet again, using a very different molecular approach, we're also able to understand whether someone would or would not respond to therapy. So just to summarize that, and I know that was quickly run through a lot of information, but in summary, what I'm saying here is that both at an epigenomic and at an immunological biomarker level, we can predict response to rheumatoid arthritis. Now, just because it's topical right now, we actually have studies ongoing with SARS-CoV-2, and we're asking some of the same questions. Can you actually use immune repertoire sequencing to predict disease progression, so whether someone will go on to severe disease or not, or again, might respond to therapies? And we're trying to use everything we've understood in rheumatoid and apply that into the COVID setting as well. So I'll finish there. I'll not go through these are the acknowledgements. I'll just put it up there, and I'd like to thank everyone that was involved. So thank you.
And thank you very much as well, Carl, for this presentation. Pretty interesting, pretty extensive, usually extremely complicated, myself true, and fascinating at the same time, everything that is dealing with autoinflammatory disease. Now, you clearly highlight that while at the moment there's no functioning biomarker, we're really putting a lot of the effort into these. There's been a huge investment in research in this direction. And I really loved your data around the BCR. My question would be to you, let's imagine that these data, and I'm sure it will be the case, it will hold true. Do you think this is scalable? In other words, do you think you can then apply really into the clinical routine?
I don't see why you couldn't. I think that the idea that we can capture this type of information now and the importance of this in terms of informing clinical decisions on how you treat someone is so important that there will be a way that we will be able to, if not do the same assay where we're sequencing everything, but at least identifying some obvious markers that we can then harness to do a targeted approach. So it'll be dependent a lot on the types of analysis we do and the results we get, but I do see the ability to translate this into a clinical setting.
Thank you very much for that. Now, to one of the question from the audience is, would you plan to integrate any kind of mutational analysis along with the analysis of BCR or TCR or any other information? So in other words, I guess the question is, how do you put the two different things together?
So that comes back to how you were asking how you translate this. I only showed you one example of the analysis we've done, which was based on CDR length. But by doing the sequencing, we are actually getting the mutation at the same time. So there's so much information in this assay, and it's about looking at it different ways, from different directions, seeing where the actual sweet spot is that can give us the information that allows us to understand each of these patients. So I would be completely inclusive in terms of the type of analysis we do for all the different parameters, and then see what comes out. And we're doing various different aspects with machine learning to try and pull out the really important pieces of this.
And I guess the last question now, before we move on to the next talk, is: this was partially done on a retrospective cohort of samples where you knew the outcome of the patient,
yep,
which of course is the first step, completely understood. Now the question is whether you're planning to go prospectively, and collect sample from patient and eventually try to really predict what's going to happen.
Absolutely. There's no other point. Like you say, the only way to do these studies in the first instance is to actually have samples in hand and no outcome, because you've got to train the system.
Yeah.
We have taken some of these forward and done blinded validation, so we know that these are strong signals. But the proof really is now to go forward to the next thing and do a trial where you can actually do stratification versus non-stratification and look for subsequent outcomes. And those studies are ongoing and planned.
Excellent. Well, thank you very much again for your presentation and for answering those questions. I guess we now move to our last speaker, and thank you very much for joining us. So we will hear in this presentation about polygenic risk score and Alzheimer's disease, and we're very much looking forward for your talk. Thank you very much.